Coming to the introduction, we all know that electrical storm means 3 or more episodes of ventricular arrhythmia requiring defibrillation or anti-tachycardia pacing within 24 hours. Sometimes electrical storm may not respond to the anti-arrhythmic drugs alone. So heightened sympathetic activity plays a significant role in the pathogenesis of electrical storm. Stellate ganglion blockade reduces the sympathetic surge. Coming to the methods, this is a prospective study. We included a patients with electrical storm and refracted to at least 2 antiarrhythmic drugs. Procedural aspects, at least 8 to 10 ml of 0.25% bupivacaine injected into the vicinity of stellate ganglion, and we will be assessing the procedural success by increasing the temperature in the epicyclator arm. At least 1 Fahrenheit should be increased. And if left stellate ganglion block is unsuccessful in controlling ventricular arrhythmias, then we will be considering for bilateral stellate ganglion block. So primary outcomes of our study is proportion of patients free from ventricular arrhythmia at 24 hours. Secondary outcomes are proportion of patients free from ventricular arrhythmia at 72 hours, all-cause mortality and CV mortality. We have done subgroup analysis for patients for the effect of stellate ganglion block on electrical storm in coronary artery disease patients without active ischemia, those who have underwent revascularization at least 72 hours before the onset of electrical storm. So here we could able to see the IJV and common carotid artery. So we will be going behind that, especially on the top of longus coelis muscle. Stellate ganglion block we will able to identify in only 70% of the patients. We will be giving at the vicinity of the stellate ganglion block, stellate ganglion. So nearly 93 patients had electrical storm in our center. Most of them, so all of them received medications, especially amiodarone, lidocaine and beta blockers wherever the possibility is their hemodynamic status is stable, and sedation also. Among them 56 patients had drug refractory electrical storm. These patients underwent initially left stellate ganglion blockade. So if left stellate ganglion block has been failed, that is if there is a recurrence of ventricular arrhythmia within 24 hours, then we will be considering the patients as a left stellate ganglion block failure and we will consider the bilateral stellate ganglion blockade. So for those patients, both left stellate ganglion blockade and bilateral stellate ganglion blockade, we will be observing the patients for ventricular arrhythmia recurrence within 24 hours and at 72 hours. So we will be analyzing the patients how much percentage of the patients had a recurrence. So if there is no recurrence, we will go for a definite treatment, whether optimization of antiarrhythmic drugs or RFA or ICD, depending upon the clinical scenario. If patient had a ventricular arrhythmia recurrence, repeat stellate ganglion will be tried. And if the patient is still having an ongoing arrhythmia, we will be considering for early RFA. So among the 56 patients, nearly 43 patients are of ischemic etiology and 13 patients are non-ischemic etiology. Of them, dilated cardiomyopathy, ARVCD, long QT syndrome, idiopathic VF, sarcoidosis, and post-surgery cases like DORV and TOF. So baseline and procedural characteristics. So coming to the characteristics, so mean age is 60 years. Most of them are 76% of them are ischemic heart disease. Nearly 14% of the patients had arrhythmia in the same hospital admission, those who had ventricular VT storm. This suggests that the patient is having a high sympathetic activity that may be the reason for atrial arrhythmias also in these patients. And nearly 65% of the patients had a heart failure at the time of admission, and 55% of the patients had a cardiogenic shock. 44% of them required IABP and inotropes. So 37% of the patients had AKI in the hospital during the hospital stay. Results. So we have done total of 83 procedures in 56 patients. So initially we will do left stellate ganglion block because bilateral stellate ganglion block requires intubation. Sometimes there is a high risk for phrenic nerve paralysis. So we will do left stellate ganglion blockade. So we have achieved nearly 66% of the patients had ventricular arrhythmia free during the first 24 hours. Nearly 33% of the patients had failure of left stellate ganglion blockade. Then we considered bilateral stellate ganglion blockade. So then we observed all these patients at the 24 hours and 72 hours. So those in the left stellate ganglion blockade patients, nearly 20% of them had a recurrence during the next 48 hours. That is, at the end of 72 hours, there are nearly 20% of them had a recurrence. So in those patients, we again consider left stellate ganglion block. If at all any failure is there, we consider bilateral also. Those patients who are in the bilateral stellate ganglion blockade category, so of them, only 1/3 of them had a success when we have done bilateral stellate ganglion blockade, and nearly 25% of them are arrhythmia free at the end of 72 hours. So all-cause mortality, our secondary outcome. So 32% was noted. Cardiovascular mortality was 18%. In them, at the time of death, the patient had a refractory cardiogenic shock was the cause of death in the patients, 14% of the patients, and refractory ongoing arrhythmia was the terminal event in 14% of the patients. One patient had AF and massive ischemic stroke, died of ischemic stroke, and another patient had a septic shock, that is multi-drug resistant Klebsiella pneumoniae. So we have done a subgroup analysis in those patients who are having a stable ischemic heart disease, that those patients who had underwent revascularization or like PTCA or CABG. After 72 hours, if they are having a onset of VT storm, we have analyzed these patients. So in a stable ischemic heart disease patients, we have analyzed the parameters to see who are at a higher risk of recurrence and who are at lower risk of ventricular arrhythmia recurrence. So patients who is having a lower ejection fraction are at higher risk of ventricular arrhythmia recurrence, and those patients who had a ventricular arrhythmia recurrence, they are at higher risk of death. Complications related to the procedure: transient bradycardia was noted in 16% of the patients, and hematoma was noted in 14% of the patient. Hoarseness of voice was noted in 10%, and we have other complications like transient cough or persistent ptosis. Those patients, in these patients, it stayed for nearly 2 weeks. And we had three patients had monoparesis, that is due to maybe brachial plexus injury, and 2 patients had seizures. Especially these patients are bilateral stellate ganglion blockade patients, where we have given at least 20 ml and above of bupivacaine. So bupivacaine toxicity resulted in the seizures in these patients. So this is our hypothesis. So interesting points in our study are: left stellate ganglion block reduces the ventricular arrhythmia episodes in at least 2/3 of the patients. Bilateral stellate ganglion block still works when left stellate ganglion block failed. Atrial arrhythmias was observed in nearly 1/7 of the patients. This may be attributed to the high sympathetic activity during the episodes. And procedure-related neurological complications like monoparesis and seizures are very rare, but we should be very cautious to avoid them. My take-home message is: stellate ganglion block is effective in the acute treatment of drug-refractory electrical storm. It allows stabilization of hemodynamic and metabolic disturbances of patients with electrical storm. It acts as a bridging procedure before the definite therapy like RFA or ICD. So, thank you. So we have recruited the patients over 5 years. So initially 5 patients in the 2018, and in 2019 18 patients. Pandemic has affected our recruitment also. Now this year we have almost recruited 16 patients for the study. Thank you.